Good morning. So I hope you all stretched your legs, had some coffee. I don't want you guys to fall asleep with me, but I'll try to make it a little bit more dynamic, or I'll try to make it dynamic. I have very few slides. And the topic I have is on updates on myeloma, specifically on bispecifics. So these are my disclosures. And I want to talk, before I talk about bispecifics, which was the meat of the talk, I want to take a few steps back and give some background so that we can better understand what a bispecific is and how it works and why we're using it, okay? So let's go back to what is myeloma. So myeloma is, we know it's a cancer of the blood. We know it's caused by abnormal plasma cells. But do you guys know what a healthy plasma cell does in our body? Anybody? Want to just shout it out? Fights infections, right? Okay, so the plasma cells in our body are producing antibodies or immunoglobulins, which are floating around in the body, and they can detect bacteria and viruses. And then once it binds to the virus or the bacteria or the foreign body, it signals the immune system to come and destroy that. So that's how we fight infections, okay? So keep that in mind, because antibodies is where all of these, the idea of how an antibody works is kind of how we ended up playing with bispecifics. So we have these antibodies in our body that fight infections, right? So if we have the ability to produce these antibodies and that can detect bacteria, viruses, foreign things, and we now have the technology and very brilliant researchers and physician scientists that can create almost anything in the laboratory, why can't we mimic a plasma cell and make antibodies that are designed to identify cancer cells as something foreign so that it can guide the immune system to come and destroy it? So the idea of that, there's several ways that we've actually played with this concept. And the first concept was monoclonal antibodies. So I think all of you are familiar with monoclonal antibodies like daratumumab, elotuzumab, or isatuximab. These are the three monoclonal antibodies that we have in multiple myeloma. And the way that they are designed is just like a normal antibody that's produced by a healthy plasma cell. It has the ability to detect a protein or part of the surface of the myeloma cell, and once it binds to it, it starts to send a signal to try to attract the immune system to come and destroy it, and kind of tell the immune system that this is a foreign body. So that's the concept of a monoclonal antibody. What's the problem with that? The problem is that the myeloma cells tend to live inside of the bone marrow, and it's part of the immune system. So it knows how the immune system works, and it's smart, and it likes to outwit the immune system by camouflaging itself. So even if you have the monoclonal antibody on the surface of the myeloma cell, sending a little beacon signal to try to bring the immune system, the myeloma cells are going to try to camouflage that messaging. So even though daratumumab and elotuzumab and isatuximab are very effective therapies that we are combining with a lot of other drugs because it makes everything better without increasing side effects that much, it's still suboptimal, and we still are not having a cure. And these drugs, as a single agent, the response rates are 30%. So when daratumumab was approved in 2015, it was approved because as a single agent, the responses that we were seeing was 30%. When isatuximab got approved, it was the same thing, 30% response rate as a single agent. When elotuzumab got approved, it got approved in combination with dexamethasone, and the combination had 30% response rate. So all three of them had between 30 and 32% response rates. So it's still a very dampened effect as a single agent. So then that antibody that was engineered in the lab got modified. And let's say, okay, instead of just relying on that beacon signal trying to attract the immune system, let's have some toxin in the antibody so that whenever it binds to the myeloma cell, it delivers the toxin directly into the cancer cell while we're waiting for the immune system to come and destroy the cancer cell. And that's what belantamab mafodotin was, or what we call an antibody-drug conjugate. Now, unfortunately, this drug was removed from the market. I don't remember if it was last year or 2 years ago. I think it was 2 years ago. There's a very high probability that it's going to come back in the market maybe next year, to be determined, but that's how that drug worked. So now how can we improve that even more? Well, have you guys seen Seeing Eye Dogs? Or, yes? What does it do? It guides a blind person, right? Okay. So bispecific T-cell engagers has a similar concept. It takes the monoclonal antibody to the next step. And instead of just binding to the cancer cell and sending a beacon signal, hoping that the immune system is going to see it or hear it and then come and bind to it and destroy the cancer cell, it actually grabs the immune cell from one side and it grabs the cancer cell from the other side. And once it has both of them grabbed, it activates the immune cell so that it can destroy the cancer cell. So it's being more proactive at dragging the immune cells to where they need to be and activating those immune cells so that it can destroy the cancer cell better. And that is actually giving us better responses. How? Well, I mentioned that the monoclonal antibodies, that the responses that we're seeing as a single agent are between 30 and 32%, right? In combination, which we always tend to use in combination, the responses are greater, in 80%, things like that. Well, bispecific T-cell engagers, as a single agent across the board in terms of the classes that there are, tend to have much better responses, more than double than monoclonal antibodies. So this system of dragging the immune cells and activating it once it binds to the cancer cell is very, very effective. And there's different targets in the cancer cell that these bispecifics are targeting. So right now, there's 2 bispecific T-cell engagers that are FDA approved. No, sorry, 3. 3 bispecific T-cell engagers that are FDA approved. 2 of them are directed to a protein on the surface of the cancer cell called BCMA, and that is teclistamab and elotuzumab. And then the third bispecific that's approved is binding to a protein on the surface of the cancer cell called GPRC5D. But there's many other proteins in the surface of the myeloma cell that we could potentially target with these bispecific T-cell engagers or with therapy in general. So we're learning in clinical trials of trying to identify new binding sites so that we're not just relying on the most common ones that we use. So why do we hear BCMA and GPRC5D so much? And are there other binding sites that we're using right now with bispecific T-cell engager? Well, we're using these binding sites for a few reasons. BCMA is expressed on the surface of the myeloma cell. Not just the majority of the expression of BCMA in our body tends to be in plasma cells. And it's more expressed in myeloma cell. And the more aggressive the myeloma cell, the more expression it's going to have. So this gives us an advantage because if we do a therapy that targets that protein, it's very likely going to target the cells that we want to destroy. Now, there are some other cells in our body that express BCMA, so that's why we see some side effects with therapies. But the majority of the BCMA is expressed in plasma cells, healthy and in myeloma cells. And that is why one of the side effects when we give therapy that targets BCMA, whether it be teclistamab or elranatamab or CAR-T, either of the CAR-Ts, or clinical trials, we tend to have hypogammaglobulinemia because we're not just destroying the myeloma cells, but as a bystander, we're destroying some of the healthy plasma cells that are in charge of making the antibodies that we need to fight infections. And then that can predispose us to infections. So that's a little downside of targeting BCMA. Now, GPRC5D is another protein that's in the surface of the cancer cell, the myeloma cell, which actually tends to be expressed mainly on myeloma cells, not on the healthy plasma cells. So unlike BCMA-directed therapy, GPRC5D-directed therapy doesn't tend to cause that much hypogammaglobulinemia as BCMA-directed therapy, but it can still cause it, okay? Now, the other thing that we're seeing with GPRC5D is that in GPRC5D, we've seen that it's not just expressed in myeloma cells, but it is also expressed in other cells that are what we call highly keratinized cells. So what is that? We see that expressed in the beds of the nail. We see it expressed in the sweat glands that don't have hair follicles, which is the palms and the soles of our feet. We also see it expressed in hair follicles, but it's expressed in the face of the hair where the hair is not active and it's dormant, so that's why we don't have any problems with hair loss. But it is also expressed in some cells that are in the base of our tongue, not the taste buds, but cells that are around the taste buds. And one of the side effects that we're seeing is that it can affect our taste because it's causing inflammation in that area. So advantages of GPRC5D is that it's mainly focused or expressed in myeloma cells and not so much on the healthy plasma cells or other cells in our body, but it is unfortunately expressed in highly keratinized cells. So that's what we're seeing, these odd side effects that we're not used to with other therapies in myeloma. But then FcRH5 is another target that has been studied and is currently being studied with bispecific T-cell engagers with a drug called cevostamab. We don't know what it does. We know it's in the surface of the myeloma cell. We don't know what it's for. And we know that it's expressed mainly on myeloma cells without it being expressed in other cells that much. So it makes it also a very exciting target to use because we don't see that much side effect toxicity because it might be expressed in other cells. So that's how we choose how to target, which bispecifics to use, and if we can find a specific target to treat myeloma. And just like these three targets, there's many other targets that we're exploring. So CD38, CD138, TACI, BAF, there's many other targets. I mean, there's a lot of proteins on the surface of the cancer cell. And we're now starting to play not just by targeting one of these proteins, but we're also trying to see, well, what happens if we target two proteins at the same time? Is this going to be more effective? And instead of calling it a bispecific T-cell engager, where we have one arm grabbing the immune cell and the other arm grabbing the myeloma cell from the BCMA or the GPRC5D, it's going to have two little arms grabbing the myeloma cell, whether it be BCMA and GPRC5D or two different targets in the myeloma cell to try to give it a bigger grip and be more effective. In case one of those proteins that's expressed in the myeloma cell might be altered or not be structured properly, and the antibody not be able to bind to it well, because that can happen. And if that happens, then the therapy doesn't work because it doesn't have the ability to bind there. So these are things that we're playing with right now in terms of how we can design bispecific T-cell engagers and what targets we can get in myeloma. So far, everybody clear? Okay, perfect. So we talked about BCMA. BCMA is the target on the surface of the myeloma cell that has been explored the most in the last 10 years because of how effective it is in terms of side effects and the fact that it's expressed very heavily in myeloma cells. And right now, like I said, we have two bispecific T-cell engagers that are FDA approved, teclistamab and elranatamab. But we have many other bispecifics that are being studied at the moment that also target BCMA. So one would ask, why do we need so many? Why is everybody playing with BCMA bispecifics if there's already two that are FDA approved? Well, they're not all the same. Even though they all target BCMA, they don't necessarily target the same part of the protein in the myeloma cell. So we have a podium here, right? I can lean on this side and push it that way. I can lean back here and push it forward. I can sit on top of it, and it's the same podium, and I'm touching the podium, but I'm getting it from different sides. And the same thing happens with these bispecifics. Each one has a different binding site of that protein. So if for some reason this protein structure is already altered or distorted, and one of these is not able to grip it properly, there could still be another one of these that can grab it from a different side and still be effective. So that's an important thing to keep in mind. Now, do we really need all five? I don't know. That's not for me to answer. But that's one unique thing. The other unique thing is the way they're formed. Some of them are humanized antibodies. Other ones are mouse-derived or animal-derived antibodies. They might have more what we call reactivity. And then the half-life of these antibodies, how it's administered. If it's a shot in the belly or if it's through the vein. If it's given once a week or if it's given once a month. If we need to do step-up dosing or if we don't need to do step-up dosing. So that's all of the little nuances between all of these antibodies, and that's why we have so many, and we're going to have a very saturated market for BCMA, bispecifics, and CAR-T. But the good thing is that in addition to the BCMA, we have the GPRC5D, we have the FcRH5, and we have other targets in the myeloma cell that we're exploring so that we can have a whole gamut of different immunotherapies and bispecifics that we can play with and try to sequence if needed. So what happens when we activate the immune system? What happens when you get a cold? Or the flu? Shout out. Anyone? Tired, sick, fever, sore throat, okay. Fatigue, yes. So, exactly. So we have an infection, right? And we have the antibodies that can detect the virus or the bacteria. And it activates the immune system. What does the immune system do? It tries to migrate to where the infection is. So in order for these cells to migrate, it needs to have some way of moving through the body to get to where it needs to be, right? So these cells tend to be floating around in the blood. But the infection is not necessarily in the blood. Infection might be in a tissue, or in the nose, or in the lungs. So how does it get to the tissue if it's floating in the blood? We need to help the vessels allow to leak some fluid out so that the cells or the antibodies can leak out into where the tissue is. So that's what we call capillary leak. And that helps the immune cells migrate to where they need to be. So that causes some inflammation and swelling in that area. So that's why if we have a cut and it tends to swell up. It gets warm as well. So fevers, chills, swelling are some side effects of when the immune system is activated. So the same thing tends to happen when we're actually activating the immune system with bispecific T-cell engagers, because it's basically, we're almost behaving as if somebody's getting the flu or a cold. It's just instead of it being a virus, it's myeloma cells. But we're activating the immune system the same way. So what tends to happen, since we're giving antibodies that are really activating the immune system, it's like giving you a symptom similar to a flu. We're causing some capillary leak so that these immune cells can migrate to where myeloma cells are, and then that can lead to low blood pressure, it can lead to low oxygen, but it can also lead to what we call cytokine release syndrome, which is a combination of fever plus minus shortness of breath because there's leak of fluid into the lungs, or hypotension or low blood pressure because there's leak of fluid out of the veins, causing the volume in the veins to drop and can cause the blood pressure to drop. So those are some side effects that we're seeing when we're activating the immune system with bispecific T-cell engagers, and not just bispecific T-cell engagers, but also with CAR-Ts. Any immunotherapy that we're using, because we're activating the immune system, we're activating these pathways to try to help the immune cells go to where they need to be and destroy the cancer cells. So we need to keep a close eye on that. And we've learned in the course of the years how to help control these symptoms without affecting the efficacy of these drugs. So I remember the first bispecific T-cell engager that we played with in multiple myeloma was a drug called Amgen 420. It was a drug that had to be continuously infused, and I actually got to give the first dose here in the United States when I was working at Wake Forest University. People always ended up in the ICU. And a good number of those patients ended up intubated for a few days because we still didn't know how to manage the fevers, we still didn't know how to manage the hypotension and the low oxygen requirements. And we were afraid of giving dexamethasone and medications that could potentially help with these symptoms because we were afraid that that would affect the efficacy of these drugs. That drug, unfortunately, never made it to the market. It got nicked. And the next one, the second bispecific, also didn't make it to the market, Amgen 424. But we learned so much from those because we learned how sick people can get and the side effects of what happens when we activate the immune system too much. And that led us to learn that we can treat these CRS by doing a few things. One is doing step-up doses before we give the full dose. So the majority of the bispecifics require some step-up doses before you get the full dose so that you don't have this huge activation of the immune system. The only one that doesn't require this is ABBV-383, which is a unique type of bispecific. It's still not in the market. Hopefully it'll make it to the market in the next year or two. But that's the only one that I would say is unique in its class, that it doesn't require step-up dosing. The other thing we learned is that you can give dexamethasone to help contain the immune system without jeopardizing the efficacy of the drug. Why? Because with bispecifics, we tend to give it over and over and over again. So even if we do give steroids that might dampen the immune system for a little bit, you're going to give it again later on, and later on, and later on. So that helps. We've also learned that tocilizumab and generic drugs like tocilizumab can be given and can help stop these side effects without affecting the efficacy of these drugs. So that's what cytokine release syndrome is. We're activating the immune system, and these immune cells are releasing these cytokines or substances that are allowing what we call capillary leak, so that these cells can migrate to where they need to be, in this case, where the myeloma cells are. But as a side effect, it can cause fevers, it can cause low blood pressure, and it can cause low oxygen or hypoxia. Nowadays, it is extremely rare that somebody who's getting bispecific ends up in the ICU or ends up intubated because of a side effect of CRS. So what are the manifestations or symptoms? Like I mentioned, chills, high fever, muscle or joint pain, nausea at times, fatigue, headaches, low blood pressure, low oxygen, shortness of breath, and sometimes confusion. Sounds like the flu, right? Minus the runny nose or any other type of infection. So that's kind of what it is, cytokine release syndrome. Now, another side effect that we're seeing with these bispecifics is neurotoxicity. So why is this happening? Or we don't really quite understand how neurotoxicity happens. We believe that this is because the same immune system that's causing this capillary leak, so that cells that are floating through the veins and the arteries can migrate into the tissue, is also causing some of these cells to filter into the CSF, the CSF fluid, or the spine, or the brain area, and the fluid that's around the brain. That's one theory. The other theory is that there might be some disruption of the barrier that divides the blood and the brain and the fluid around the brain, and that some of these antibodies might be leaking into that area and might be activating any immune cells that might be there and causing some inflammation that can cause some confusion or these neurological changes. This can happen on its own, or it can be happening hand in hand with CRS, or the cytokine release syndrome, which is the fever with the hypotension and the low oxygen. It tends to occur more commonly hand in hand with CRS or after CRS. And we've learned how to treat it by giving dexamethasone, because it helps with the inflammation, or another drug called anakinra, which also helps with the inflammation. And all of the patients that have developed this neurotoxicity in bispecifics, their symptoms tend to resolve once we give the dexamethasone or the anakinra. So what are the symptoms of neurotoxicity, or what we call ICANS? You can have some headaches, confusion, some tremors, some sleepiness or drowsiness, problems swallowing, problems speaking, some problems moving, some paralysis of facial nerves, and in very severe cases, you could have seizures. I have not experienced that yet, but it's something that has been reported. So these are all symptoms that tend to be related to having an irritation or inflammation of the brain or nerves that are around the brain or the spinal cord. And other side effects that we're seeing with bispecifics is it can cause your white count to drop transiently, especially in the first week of the treatment during the step-up doses, and then this tends to recover with time. But then with time, especially if we combine it with other drugs, it can also cause low white count or low platelets, but not that severe as conventional chemotherapy. It can cause hypogammaglobulinemia, like I said. BCMA-directed bispecifics destroy not just the myeloma cells, but they tend to destroy the healthy plasma cells. So then we don't have enough production of immunoglobulins, which can cause hypogammaglobulinemia and increase the risk of infections. So we tend to give IVIG on a monthly basis while people are getting BCMA-directed bispecific therapy or CAR-T to try to reduce the risk of infections. And then for those who are receiving therapy with GPRC5D-directed treatment, the only one commercially available right now is talquetamab. It has what I mentioned. Because it's expressed in keratinized cells, the nails change, and they tend to get flaky and sometimes fall. The taste, the majority of the patients will have some change in their taste, and desquamation or peeling of the palms and the feet. Those are very common side effects that we see with talquetamab, which is the only GPRC5D-directed therapy that's currently available for myeloma. And those are some of the nail changes that you tend to see. So when do we use bispecifics? And I have only 5 minutes, so I'm going to be very fast on this. So right now, the indication and the FDA approval for bispecifics is anybody who has had at least 4 prior lines of therapy and have been exposed to a monoclonal antibody, so daratumumab or isatuximab, a proteasome inhibitor, so bortezomib or Velcade, carfilzomib or Kyprolis, or ixazomib, Ninlaro, and an immune modulator. So lenalidomide or Revlimid, pomalidomide or Pomalyst, or thalidomide, which we rarely use nowadays, or Thalamid. You have to have exposure to those 3 drugs or have a contraindication to one of those 3 drugs in order to then qualify to be able to receive one of the commercially available bispecifics, whether it be teclistamab, elranatamab, or talquetamab. And as soon as we can get somebody to have 4 lines of therapy, we're going to use that, because by the 4th line of therapy, we really don't have that very effective options other than CAR-T and bispecifics. But nowadays, we're starting to use these drugs in clinical trials earlier. Why? Because we know that these are very effective drugs. And in myeloma, we want to use our best drugs first, up front. Why? Because our first shot is always our best shot at 2 things, at getting a deep response and at getting a durable response. And then when somebody relapses, they might relapse 3 years later, 8 years later, 10 years later, or 1 year later. But 1, we're going to be older. 2, we might have other medical problems going on. 3, we might be weaker. So there's a good high percentage of patients that cannot get a second therapy or a third therapy for reasons other than the myeloma itself. So that's why we want to use the best drugs early, first, so that we can get our best shot. So now we have clinical trials with all of these bispecifics. At first relapse, 1 to 3 lines of therapy. We're having clinical trials for people up front who are transplant ineligible and combining it with the standard of therapy that we're using right now. We're also doing clinical trials, seeing if doing a bispecific after transplant as part of maintenance instead of lenalidomide or Revlimid might be better, more effective, and better at controlling the disease. And that way, we don't need to be worrying about relapse in the future. But these are all clinical trials that are ongoing right now. And the other thing that we've learned is these bispecifics, as a single drug, the response rates tend to be between 62% and 72%. So it's definitely double the percentage than the monoclonal antibodies like daratumumab and elotuzumab and isatuximab. But we're greedy in myeloma. We want 100% response rate. So what are we doing? We're combining these bispecifics with other therapies, just like we tend to do in myeloma, where we tend to combine Dex with POM or Dex with Len and carfilzomib or Dara or whatever agents that we have. So we've been mixing these bispecifics with pomalidomide, with lenalidomide, with daratumumab, with other drugs that are currently being explored to try to see if these combinations give us better responses. And we are seeing better responses. And these response rates from 62% are going up to 76, 78%, so an increase of more than 15%. We're also seeing an increase in side effects too. So we're still learning, trying to figure out which is the best pair of these drugs to make these bispecifics more effective without increasing the toxicities that much, while the drug companies get their act together and come up with a better bispecific that doesn't cause any side effects and is 100% effective. But we'll cut them some slack. You heard that? Okay. So we have all these combinations. Right now, we don't know how to choose what's the best therapy in myeloma because we have so many treatment options that if we actually ask the doctor, okay, this is the second relapse, this is the third relapse, this is the fourth relapse, what combination of drugs should we use? There's never been a head-to-head comparison study to try to determine which of these combinations is the best one. That's going to be a big challenge because that's impossible to do. So there's a lot of factors that influence how we choose what is the best next drug for that patient, and that's personalized care. We need to take the individual and see, okay, what is your age? How strong are you? What other medical conditions do you have? What are the social conditions? Do you have family support? How far are you from the center? Are you afraid of needles or not? Can you take things by mouth or not? All of these factors. What's your insurance? Because that also plays a very important role too, especially when it's oral drugs. And if you have a deductible or a copay and things like that. So these are all very important things that we need to keep in mind so that we can personalize the care for that individual that is in front of us that has relapsed myeloma or newly diagnosed myeloma, and we need to come up with a strategy. And the decision is made as a team. The decision is not made by the doctor, it's made as a team. The patient and the doctor need to agree on a treatment together. And I want you guys to leave here knowing that. You guys are as empowered at deciding what's going into your body and how you're going to manage your myeloma as the doctor is. Because in the end, it's your life. It's not the doctor's life. And you're the one that's going to live with the consequences of what you're receiving. So be sure that you're comfortable with whatever decision or recommendation the doctor is asking. Ask questions so you actually learn and understand the decision, why you're taking that therapy or you're making those decisions, and be comfortable enough to say, okay, this is a decision that we make as a team together. So these are the two agents that I said are approved, the teclistamab and elranatamab that target BCMA, and this is the talquetamab that targets GPRC5D.